So greeting from ASCO, Chicago 2018. What I would like to discuss with you today is the definition and the management of high-risk follicular lymphoma patients. Follicular lymphoma is usually seen as an indolent lymphoma with a long-lasting natural history. However, there is a significant proportion of patients who behaves with a more aggressive disease and for whom the life expectancy and the duration of a residual life is seriously affected. The problem that we have is twofold. The first problem is how to define patient at high risk, and the second problem is how to treat them. What treatment should be discussed with the patient who is at high risk. The most important part today is the definition of high risk. We recently have learned that the most important prognostic factor and prognostic definition of high-risk patient is with the duration of response. We clearly know that patients that relapse early after the time of diagnosis, usually within the first 2 years, behave poorly compared to those patients who relapse later than 2 years or who do not relapse. This is the concept of POD24 that is shown to be significantly associated with the shorter PFS, but also with a significantly and clinically significant shorter overall survival. The problem with POD24 is that it is after 2 years, so it would be better to have earlier endpoints, earlier prognostic scores that help us to identify as early as possible the patient who will behave as an aggressive follicular lymphoma. For the time being, we have several factors. Most of them are predictive of progression-free survival. Only few of them are significantly associated with overall survival, and we can divide them into two groups. Those factors that can be assessed at baseline. These include the clinical factors like FLIPI or FLIPI2 that are very commonly used and are very important, but none of them is decisional. We have the newest factors like the total metabolic tumor volume that tries to define to quantify the disease amount and to correlate it with prognosis. This is relevant not only for PFS but also for overall survival. And we have the newest biological and clinical factor prognostic scores that are M7 FLIPI or a new 23 gene model prognostic score that are of course being the newest need further validation in a clinical setting. Then we have the post-induction prognostic scores that include mainly the evaluation of response. We have we have the metabolic response concept that uses PET to define response, and include the concept of a complete metabolic response as a favorable predictor of outcome. And patients with incomplete metabolic response behave poorly and with a higher risk of early progression and higher risk also of higher risk of dying for the disease. And then we have other concept of that assess response, including molecular response, using the assessment of T1418 or the rearrangement of immunoglobulin with the eye-sensitive techniques. So we are very good in defining prognosis. We have different tools, but what we don't know exactly is how to integrate these tools together to try to overcome the major problem that is the low accuracy in defining and anticipating the prognosis of the patient. So in the future, probably we will need integrated tools to better define the prognosis. And this is the most important thing that we want to develop a risk-adapted treatment strategy. As far as treatment of high-risk patient, follicular lymphoma patient is concerned, we really have very few data from the literature that can support us in the discussion with the patient on which is the best treatment for a high-risk patient. We do not have risk-adapted treatment approaches and programs already published and validated for follicular lymphoma patients. There are some studies, some clinical trials that are currently ongoing and are using metabolic and molecular response to try to adapt the post-induction treatment in patients who behave differently and have different outcome based on metabolic and molecular response. And we don't have any ongoing treatment or that can be supposed to provide data in the next years on baseline risk assessment and baseline risk-adapted approaches. As far as the really high-risk patients that we know are at high risk of dying from the disease, those are those patients who relapse early. We don't have randomized trials that help us to define which is the standard for treatment in this patient, but we have clearly defined guidelines that are shared by most of the societies, international societies and associations that clearly state that based on the general consensus, that those patients who relapse early should not be considered as having an indolent disease, but should be considered as having an aggressive disease, and this is the reason why intensified treatment are recommended, including the adoption of, if possible, of high-dose therapies and with the support of autologous stem cell support. So for the time being, the problem of high-risk patients with follicular lymphoma is a really burning problem that is raising burning question on the definition of the disease of this aspect and the definition of a treatment option. And we'll see in the next year with the new data from ongoing trials if we have new answers to these questions.